Hi folks, welcome back to Prepladder NEET SS. This is your medicine faculty, Dr. Santosh Patil. And in this video module, I will be discussing key points about sarcoidosis. For a postgraduate student, this topic does not require any introduction. You're all familiar that this could be your main question, this could be your short question, and this is the grounds for plenty of MCQs in your NEET SS as well as INI SS. Our primary focus will be to address this topic from the perspective of what can be asked as an MCQ, but this objective information will also anchor your 20 marks answer in your PG exam. Let us begin by first defining what is sarcoidosis. Okay, can anybody make an attempt to define sarcoidosis? How would you define it as? Okay, so let me put a very simplistic definition of sarcoidosis. Sarcoidosis is a multi-organ inflammatory disorder, multi-organ or multi-system inflammatory disorder characterized by, because see, we know a lot of other disorders where multiple organs are affected with inflammation apart from autoimmune disorders like autoinflammatory syndromes, your familial Mediterranean fever, all those are also multi-organ inflammatory disorders. So definition should differentiate it from, right? So it's a multi-organ inflammatory disorder characterized by formation of non-caseating granulomas. Formation of non-caseating granulomas. Okay, so this is the simplistic definition. This definition helps us to separate sarcoidosis from some other conditions which can confuse us. Like the autoinflammatory syndromes are also multi-organ inflammatory disorders, but there is no granuloma formation. Then tuberculosis can affect multiple organs where inflammation can be triggered because of the infection, and there is granuloma formation. But in case of tuberculosis, those are caseating granulomas. So this is how definition helps us to distinguish and set clearly what is sarcoidosis. Now that we're talking about a disorder which is affecting multiple organs, there can be a question asking you what is the most commonly affected organ, and it needs no introduction because you're already watching this video module under the respiratory system. So it goes without saying that the most commonly affected organ is going to be respiratory system or lungs. Most commonly affected organ is lungs, and most of the patients get diagnosed because of the respiratory system manifestations and not because of the other organs. There can be an occasional question asking you what is the second most commonly affected organ, or what is the most commonly affected organ after the lungs, and it is skin. It is not the cardiac sarcoidosis, it is not neurosarcoidosis, or it is not the exocrine or endocrine manifestation. It is skin. Skin is the second most commonly affected organ. Okay, now that this is a inflammatory disorder affecting multiple organs, something should trigger, right? As of now, the understanding of the pathogenesis of sarcoidosis is kind of limited. There are plenty of hypotheses implicating multiple organisms, genetics, as well as certain chronic workplace related exposures like beryllium, but concrete evidence favoring any one of them lacks. If at all you ask me to pick one, probably I would say infections, most importantly tuberculosis, because see, what is setting it apart? Caseating versus non-caseating. That is what is setting apart the tuberculosis from sarcoidosis. Otherwise, you will probably agree that there are a lot of similarities in terms of clinical presentation. And there are a lot of studies which also mention that from the granulomas, they were able to isolate the tubercle bacilli. So that probably makes me think that tuberculosis might be an important inciting event for the pathogenesis of sarcoidosis. Probably something in the genetics or immune system facilitates formation of non-caseating granulomas over caseating granulomas. That's my take on it. Okay. Now, obviously, there may be well-established risk factors. So let us look at the risk factors for sarcoidosis. Number one, age. Yes, most of the patients who are diagnosed with sarcoidosis are typically middle-aged patients. Okay, so most of them are middle-aged. It is more common in females. So you can say that it is typically a disorder of the middle-aged female. But we have to remember that sarcoidosis can occur at any age. Though it can occur at any age, the usual age of presentation is 25 to 40 years. Recent times, there is increasing prevalence of sarcoidosis in the pediatric age group. Geriatric age group, we were already recognizing it. It is, some of them are like late diagnosis, though patient may be having the symptoms for quite some time. They're getting diagnosed late. But nowadays, we are also recognizing it in the pediatric age group. Gender-wise, as I've already told you, females are more affected than males. There is certain characteristic HLA association. There is increased risk of developing sarcoidosis in those who are carrying HLA DR 11, 12, 14, 15 and 17, and those who are carrying HLA DR 1 or DR 4 or DQ0202 carry decreased risk of developing the sarcoidosis. Pretty easy to remember. If at all there is a question asking you about the HLA and risk of sarcoidosis, right? Think of all double-digit numbers associated with increased risk and single-digit numbers associated with decreased risk, right? Smaller the number, lower the risk. Bigger the number, higher the risk. That way you can remember it. Now, if you look at ethnicity, African blacks are the most affected. But for cardiac sarcoidosis, for some unknown reason, the Japanese are most vulnerable. So when African blacks are affected, obviously it is the typical presentation. Lungs are the most commonly involved organ. But when it comes to the cardiac sarcoidosis, we have to remember that it is the Japanese who are at increased risk of developing cardiac sarcoidosis. Okay. Then occupation can be a risk factor, particularly agriculture, healthcare workers, right? And then firefighters, mechanics, and those who are working in Navy are believed to be at increased risk. There are various hypotheses behind this, right? Healthcare worker probably because of exposure to infections, particularly tuberculosis. Then firefighters and mechanics because of the exposure to the particulate matter or particularly beryllium. Okay. Navy also believed to be because of the exposure to particulate matter and beryllium and also organic dust on their working places. Agricultural again related to organic dust. So these are believed to be the risk factors for sarcoidosis. Okay. Now talking about the pathogenesis, it's pretty simple, right? Our understanding is very limited, but it is believed to be an autoimmune disorder, and the triggering factors are believed to be mostly the infections that we were talking about. There are two important infections I want you to remember. One is Mycobacterium tuberculosis, atypical mycobacteria, and the second organism which has been increasingly implicated is Propionibacterium acnes. Propionibacterium acnes. Okay. Other than that, exposure to particulate matter, particularly the one that contains beryllium. Okay, now these all can act as antigens, and the antigen presenting cells will recognize them and present it to T cells. Patients probably will develop sarcoidosis if they have impaired T recognition cell response, or for some unknown reason like variations in their interferon gamma expression, TNF alpha, or various interleukin expression facilitates granuloma formation. Okay, so there is a formation of granuloma, and these granulomas can lead to clinical manifestations because of either local tissue effects, distortion of the tissue architecture, or because of the compression of the surrounding structures. They lead to organ manifestations. Okay, now if this can happen as an acute form also, and if there is a good immune response from the patient side, then there may be antigen clearance and patient might go into remission. Or some patients where the antigen clearance fails to happen, they can go on to develop chronic sarcoidosis. Okay, so mainly what can be asked, they will mostly ask which infections are implicated and which metal toxin has been implicated. Okay, that's it about the pathogenesis. Okay, now let us talk about the organ system involvement in the headings of clinical features. So when I'm talking about clinical features, we already know that most commonly affected organ is lungs, right? So when it comes to lungs, what is the clinical presentation? Symptom wise, most of these patients present with cough and dyspnea. Cough and dyspnea. Cough is usually dry cough or non-productive cough. So when patient presents with subacute to chronic cough and dyspnea, sarcoidosis should be one of our differential diagnoses. Obviously, there are other important differentials to consider, including interstitial lung disease, COPD, bronchial asthma, tuberculosis. All of those are important differential diagnoses. Okay. Now, such a patient, when we're evaluating, if we do a chest X-ray, what are the findings we will be seeing? See, most importantly, what we might see is, I will tell you that the sarcoidosis affects airway as well as lung parenchyma. Okay, so the airway involvement is also there and the lung parenchyma involvement is also there. So airway involvement can lead to obstructive lung disease. So if it is exclusive airway involvement, you might have the typical obstructive PFT picture. But most cases, more than airway, there is involvement of parenchyma. Parenchyma involvement is much more common, and here it will lead to a restrictive PFT picture. Okay, so if you evaluate on the PFT, you might see some restrictive picture, and this restrictive picture is because in the parenchyma, basically there are granuloma formations in multiple locations. So what are the locations? Well, lung fields typically affected, plus there is also hilar lymph nodes. Hilar lymph nodes. In both these places, there is granuloma formation. Okay, and this may be evident on the chest X-ray. So if you do an X-ray, you might see patient has got granulomas leading to like infiltrative changes. Right? These granulomas might lead to infiltrative appearance on the lung parenchyma or lung fields. Plus you will have enlarged hilar lymph nodes. This is the usual presentation, right? So this presentation is quite similar to the presentation of tuberculosis. So tuberculosis is the closest differential diagnosis. Okay, so if you do a chest X-ray, these are the findings. If I do PFT, I might get obstructive or restrictive or a mixed picture. There can be one important MCQ asking you, what is the most common PFT abnormality in patients with sarcoidosis? So the most common PFT abnormality, because parenchymal changes are the earliest one. See, why there is granulomatous, why there is airway changes in patients with sarcoidosis? Because the granulomas can happen in airways also, leading to obstruction. But those granulomas will manifest with obstructive disease when there is a significant load of granulomas. So it's like a late manifestation. So the starting point is rather hilar lymph nodes and lung fields. So this lung field involvement will impact on the PFT, and that would be in the form of decrease in the diffusing capacity. So DLCO will be decreased, and that is the most common PFT abnormality in patients with sarcoidosis. Okay, as the condition progresses, when the sarcoidosis is more extensive, that is where the restrictive picture becomes evident. If there is involvement of airway, then you might have obstructive picture, but this is the most common PFT abnormality. Okay, and based on the radiological appearance, there is a staging system involved for sarcoidosis. So for an MCQ, they can ask you what is the staging system for pulmonary sarcoidosis, and that is SCADing staging. That is called as SCADing staging for pulmonary sarcoidosis. So according to this, there are 4 stages of sarcoidosis. So what happens in stage 1, 2, 3 and 4? Sometimes they might give you an image and ask you which stage it belongs to. Okay, so stage 1 is where you will see only hilar lymphadenopathy. That is the starting point. Hilar lymphadenopathy and no parenchymal changes. That is stage 1. No parenchymal changes. So what you would see in stage 2 is you have hilar lymphadenopathy, but in addition to hilar lymphadenopathy, now you also have lung parenchymal changes. So it starts with hilar lymph nodes. Subsequently, lung parenchymal changes start appearing, basically infiltrative changes in the lung fields. Then it will progress further. So here we have hilar lymph nodes plus parenchymal changes. That is our stage 2. Okay, now what happens in stage 3? In stage 3, whatever you saw, right, in stage 2, the hilar lymph nodes but parenchymal changes, now hilar lymph nodes start disappearing, but parenchymal changes persist. They might increase. So in stage 3, we only have parenchymal changes. There is no hilar lymph nodes, but there is certainly parenchymal changes. So hilar lymph nodes are not there, parenchymal changes are present. That is stage 3. Stage 4 is where you have extensive fibrosis. Stage 4 is where you have extensive fibrosis. Basically, this is a stage where patients can be like clearly identified on chest X-ray as a case of interstitial lung disease. This is the SCADing stages of pulmonary sarcoidosis. Image-based questions are possible, so let us take a quick look at the images. So as you see in this image, first image, you can clearly identify that there is hilar lymph nodes. There is no lung parenchymal changes, so that is stage 1, only lymphadenopathy. Look at the next image, stage 2. You can identify hilar lymph nodes as well as you can see lung parenchymal changes. Infiltrative changes or fibrotic changes are evident in the lung parenchyma. Okay, as you progress in stage 3, you can see infiltrative changes, but the hilar lymph nodes are almost disappeared. infiltrated. This is stage 3. Only infiltrates is what you are seeing. Stage 4 is where you have extensive fibrotic changes, a very typical ILD-like X-ray. That is stage 4, right? Quick summary, what do we see in stage 1? In stage 1, only lymph nodes. Stage 2, lymph nodes plus parenchymal changes. Stage 3, only parenchymal changes. And stage 4, extensive fibrosis or ILD-like chest X-ray. This is about the scattering stages of the sarcoidosis. Okay, so now we are done with the most commonly affected organ, that is lungs, right? So lungs, it can cause airway disease as well as parenchymal disease. It can cause obstructive as well as restrictive lung disease. Mostly starts with restrictive lung disease, hilar lymphadenopathy and parenchymal changes, and that's why it resembles tuberculosis. Okay, now let us talk about the second most commonly affected organ. Yeah, I forgot to mention you this point. Normally, in patients with the sarcoidosis, if you take the bowel fluid and take their CD4-CD8 ratio, it will be more than 3.5. This is an important MCQ point which has appeared multiple times in the MCQs. So the bowel CD4-CD8 count ratio in patients with sarcoidosis is more than 3.5. Okay. Now let us talk about the second most commonly affected organ, that is skin. What is the second most commonly affected organ? Skin. What are the important manifestations? There are two important skin manifestations that we need to remember. The first one, I will be calling it as lupus pernio. In 2017 NEET assess, there was an MCQ asking you lupus pernio is seen in which of the following disorders? SLE, rheumatoid arthritis, sarcoidosis, and something else. Many students had picked up SLE because the word lupus, right? Lupus tricks us to think that it is SLE, but this is different from SLE. At the look, at least some of you may think like, okay, sir, there is malar rash and there is also nasolabial fold sparing. So why don't we call it as SLE? Well, it resembles SLE malar rash. That is why the term lupus comes into picture. But the difference is SLE malar rash is just the erythema, right? It is not a palpable rash, but the lupus pernio is a palpable rash. So what you're seeing here, right, all these erythematous areas, these are the areas where underneath the skin, like including the skin, there are granulomas. In the SLE, there are no granulomas, so it is a flat lesion. It is not a palpable lesion. But in case of this lupus pernio, these are palpable lesions. So if someone presents with a malar rash, well, melasma, cloasma are differentials. Your SLE malar rash is a differential, but also keep in mind, because this is also a middle-aged female that who is presenting with this symptom. So sarcoidosis is also a possibility. So just run your fingers on the rash and see if it is a palpable rash or whether there is induration. If there is induration or it is a palpable rash, then it is lupus pernio, leaning more towards sarcoidosis. Okay, that is one manifestation. And the second manifestation that you can see here, I think you can notice that there are erythematous rashes here. Again, these erythematous rashes are because of same thing that you saw in the lupus pernio, because of the granulomas, non-caseating granulomas. So these are also going to be palpable, right? So what do we call this as? This will be called as erythema nodosum. Erythema nodosum, right? Name itself tells us that there is erythema and there is nodularity, right? Palpable rashes. Erythema nodosum and lupus pernio are the important skin manifestation. Point to note, this is the second most commonly affected organ. Okay, now let's move to the next organ, that is cardiac sarcoidosis. Okay, what are the manifestations that we can see in a patient with cardiac sarcoidosis? Number one, we can see them presenting with heart blocks or AV blocks. Rarely even the SA exit blocks, but most commonly AV blocks. Sometimes they can present with ventricular arrhythmias. Okay. They can also present with heart failure. Both acute as well as chronic heart failure can be a presenting feature. Okay, now why all these manifestations are happening? Again, because of the formation of granulomas. Most commonly, granulomas compress the conducting system of the heart. When granulomas expand, right, they compress the conducting system of the heart, and that leads to development of heart blocks. So if there's a question asking you what is the most common manifestation of cardiac sarcoidosis, your answer should be it is the heart blocks. So heart blocks are the most common manifestations. Ventricular arrhythmias are rare. Heart failure is relatively common. Okay, heart failure is because of multiple infiltrations or granulomas in the left ventricle, leading to ventricular dysfunction and heart failure. Okay, now there can be an MCQ asking you what is the investigation of choice for cardiac sarcoidosis, right? The investigation of choice for cardiac sarcoidosis will be either you can go for the PET-CT, or you can do a cardiac MR with gadolinium enhancement. Okay, what would we see in these patients? There are multiple areas of granulomas which are inflammatory, right? So they are metabolically active, so they will have tracer uptake more than the surrounding tissue where granulomas are not there. So in simple words, we will see patchy increase in tracer uptake in the myocardium. That is what we will be seeing on the cardiac MR or PET-CT. Okay, so that's how we would diagnose. Obviously, cardiac biopsy is not feasible or not considered a important choice. Okay, so this is about cardiac sarcoidosis. Now let us talk about the neurosarcoidosis. Question can be asked, what is the most common manifestation of neurosarcoidosis? And if there's a question asking so, please remember the most common manifestation of neurosarcoidosis is facial nerve palsy. Facial nerve palsy, which can be unilateral or bilateral, but most often it is bilateral. It can be unilateral or bilateral, but it is most often bilateral. And whether it is going to be element type or UMN type, let me tell you, it is going to be element type. Now tell me what could be the potential reason. Element type. It is because most often the facial nerve gets compressed by the granulomatous lesions in the parotid gland or adjacent structures, and in that case obviously it is going to be element type of the facial palsy. Okay, what else we can see? We can also see these patients presenting with aseptic meningitis. Okay, the parenchymal lesions are extremely rare as such, but aseptic meningitis, these patients can present with facial palsy. These patients can present with increased intracranial pressure or intracranial hypertension, right? Intracranial hypertension. So these are all important neurosarcoid manifestations. Important take-home message is facial nerve palsy is the most common manifestation. Okay, now talking about the eye involvement, it is mostly in the form of uveitis. Retinitis or vitreal inflammation is rare. Uveitis is the most common, and to be more precise, it is the anterior uveitis which is most common ocular manifestation. Okay, now renal wise, the most common manifestation will be in the form of interstitial nephritis. That will be in the form of interstitial nephritis. Most often difficult to recognize. Most cases get diagnosed with the sarcoid-induced interstitial nephritis after already having established the diagnosis of sarcoidosis because of the other organ involvement. Okay, now endocrine manifestations, the granulomas can affect the pituitary gland. So you can have hypopituitarism because of the granulomas affecting the pituitary gland. The granulomas can happen anywhere in the pituitary gland, but the stark compression is the most common manifestation. Okay, so it can be presenting as diabetes insipidus in some of the patients. Okay, apart from that, one important change that we would see with respect to endocrine system in sarcoid patient is there will be increased conversion of 25-hydroxy vitamin D to calcitriol because of the increased activation of macrophages. So macrophages are like involved in the granuloma formation, right? So those macrophages can accelerate the conversion of 25-hydroxyvitamin to calcitriol, and this calcitriol will obviously increase calcium absorption in the gut, and that can lead to hypercalcemia and hypercalciuria, right? So patient can have hypercalcemia, and once your blood calcium is high, that can result into hypercalciuria. So these are important endocrine manifestations. Okay, with respect to hematological manifestation, MCQ can be what is the most common? The most common manifestation will be lymphopenia. Lymphopenia will be the most common manifestation. Apart from that, you can develop anemia. Anemia, if it happens, it can be most likely a anemia of chronic disease type. Okay, so this is about the hematological manifestation. Okay, now apart from the chronic manifestations, some of the patients can also present with acute sarcoidosis. There are two important syndromes to remember here. Number one is called as Lofgren syndrome. Okay, so this is a acute sarcoidosis, and let me tell you that whenever you talk about acute sarcoidosis, the prognosis is better in comparison to chronic sarcoidosis. Better prognosis than chronic sarcoidosis. It is probably that whatever triggered the formation of sarcoidosis, the immune response was much profound, and thus there is efficient antigen clearance. So initially you have some symptoms, but there is efficient antigen clearance and patient will go into remission most cases. And if you give steroids, the response is even more beautiful. In case of chronic sarcoidosis, probably the immune response is not sufficient enough to achieve the antigen clearance, and that is why we have granuloma formation for containing the antigens. Okay, so in Lofgren syndrome, usually patients present with the fever, erythema nodosum, and hilar lymphadenopathy. Some of the patients might have ankle arthritis along with that. If you remember, when I defined the condition for you, I told you that it's a multi-organ disorder characterized by inflammation leading to non-caseating granuloma formation. The important reason why I stressed on the definition is sometimes autoinflammatory syndromes can also present like this, right? Ankle arthritis is one of the common manifestation of familial Mediterranean fever and various other autoinflammatory syndromes. So like patient will present with fever, they can have erythema nodosum or other skin rashes also, and they can have ankle arthritis. That is why we should be aware that sarcoidosis is one of the differential for such picture. Lofgren syndrome means fever plus erythema nodosum plus hilar lymph nodes plus or minus ankle arthritis. We have one more acute condition which is called as Hereford syndrome, which is also known as uveoparotid fever. So as it says, fever is there should be involvement of uvea. So you have anterior uveitis, and then you have bilateral parotitis. And because the parotid gland is now inflamed and loaded with the infiltration, it can cause facial nerve palsy. Facial nerve palsy may be there at the presentation or may not be there, but these three things are usually standard: fever, febrile, uveitis, and parotitis. Parotitis is usually bilateral. Uveitis can be bilateral or unilateral, but it is usually anterior uveitis. So these are two important acute syndromes associated with sarcoidosis. So this is about the clinical features. Now let us do some quick post-mortem of the points, and then we will discuss about the diagnosis. So what we have learned so far: what is the most common cardiac manifestation? It is the heart blocks. The reason I'm doing this is all these are important MCQ points. What is the most common renal abnormality? That is interstitial nephritis. Okay, what is the most common neurological manifestation? Seventh nerve palsy, which is often bilateral. If both are mentioned, bilateral and unilateral, I would definitely go with bilateral. Okay, what is the biomarker useful for the prognostication of sarcoidosis? Okay, so what biomarker can be useful? You can think about serum ACE levels, and we can also think about CRP, but the most important one is ACE levels. We will learn about it in a bit. Okay, now what is the name of the staging system used for the sarcoidosis? That is going to be SCADing staging for sarcoidosis. Okay, what are the acute forms of sarcoidosis? We have learned about two forms. One is uveoparotid fever, which is also called as Hereford syndrome, which is characterized by anterior uveitis, bilateral parotitis, and fever with or without facial nerve involvement. And then we had one more called as Lofgren syndrome. Lofgren syndrome, where patient has fever, erythema nodosum, bilateral hilar lymphadenopathy. Often they might have ankle arthritis. Okay, so these are important MCQ points. Now let us talk about the diagnosis of sarcoidosis. By this time, we clearly know that tuberculosis is one of the important differential diagnoses. So ruling that out will be part of our diagnostic criteria. Okay, so what diagnostic criteria says is that patient should have clinico-radiological picture suggestive of sarcoidosis. Okay, plus the second criteria. So this is like, let me put it in a box so that you can write it in the paper easily. Clinico-radiological picture suggestive of sarcoidosis. What is clinical picture? Like respiratory system is most commonly affected, so patient will have cough and dyspnea. And maybe there is also skin involvement or other organ manifestations. Radiological picture is mostly hilar lymphadenopathy and lung parenchymal changes. So if you have that in mind, so you can start thinking about sarcoidosis. Then the second thing is the serum ACE levels should be more than 3 times the upper limit of normal. So patients with sarcoidosis are generally characterized by elevated serum ACE levels, and serum ACE levels have an influence on the prognosis of sarcoidosis. Okay, then the third thing is we should also have we need to rule out tuberculosis, right? How do we rule out? The sputum test is not adequate. Like if you're doing the Ziel-Nielsen stain, it is not adequate because we know that it may not have the sufficient pickup rate. So we need to have more sensitive tests for a detection of tuberculosis here. So the negativity is needed for negative test results for either you can go for the CBNAT or you can go for interferon gamma release assay like TB quantiferon gold. Those tests are recommended, not your sputum ZN stain. Okay. Now with this, right, this will give you the context to suspect the sarcoidosis. The next thing is we need to confirm the sarcoidosis, right? So let me put it under the B so that you can clearly remember it. Now, how do I go ahead and establish that this is sarcoidosis? For that, either I need imaging findings typical of sarcoidosis or biopsy of the affected organs suggestive of non-caseating granulomas. And because see, the lungs is most commonly affected. See, most of the guidelines generally mention this on top and the imaging findings in the bottom, but I am reversing it because most commonly affected organ is lungs, where getting the lymph node biopsy or lung parenchymal biopsy probably is not called for, and we can make a diagnosis with the imaging modalities itself. Okay. Now, if at all we're talking about imaging modalities, I have mentioned here typical of sarcoidosis. So what are those typical imaging formats of sarcoidosis? So we have to remember here that the investigation of choice is not going to be chest X-ray. Chest X-ray might facilitate the staging, but that's not the investigation of choice. The investigation of choice is going to be either PET CT or gallium nuclear scan. Okay, so on these scans, we will be mainly looking for two named signs. One is called as panda sign and the second one is called as lambda sign. Lambda sign. Okay, what is panda sign? So when we do PET CT, the granulomatous changes are affecting the orbits, they are affecting the nasopharynx and parotids, we already know, right? So the increased tracer uptake in these locations or increase in nuclear activity on the gallium scan in these locations might make the scan image look like the face of the panda. That is what we call as panda sign. So it means there is increased uptake in bilateral orbits plus nasopharynx plus bilateral parotids. So this gives rise to the appearance of the face of the panda, and that is why we call it as panda sign. Another one is with respect to the thorax. So in the thorax, there will be increased tracer uptake in the bilateral paratracheal, plus there is also pretracheal lymph nodes. Pretracheal lymph nodes. So this leads to what is called as lambda sign, because that whole image appears like the lambda sign. Now both of these are important image based questions, so let me show you the images so that you can remember the stuff well. So this is the first scan where you can clearly see the increased tracer uptake in bilateral orbits, nasopharynx and parotids, right? So this kind of looks like the face of the panda, so that is why we call this as panda sign. And in the second image, you can see that there is increased tracer uptake in the bilateral paratracheal, and also there is increased tracer uptake in the pretracheal, and this kind of looks like the lambda. So this is why this is called as lambda sign. Okay. Now both these signs are considered as typical radiological findings of sarcoidosis, and they can be used for the diagnosis, especially when biopsy of the affected organ is not feasible, right? You can also consider cardiac MRI for the imaging findings if it is the cardiac sarcoidosis that is the presenting feature and you don't have the strong evidence of lung involvement. Lung involvement is seen in more than 90% patients, but sometimes the remaining 10% might present with skin or the cardiac or neurosarcoid. In those cases, cardiac MRI can also be, or cardiac PET can also be considered for the imaging evidence. Okay, so to sum it up, the diagnostic criteria, number one, there should be clinical radiological picture which suggests that patient may be having sarcoidosis. TB should be ruled out with CBNAT or IGRA. Serum AC level should be more than 3 times upper limit of the normal. In such a patient, we need to prove that there is non-caseating granulomas affecting those organs, right? That can be proved with either biopsy, or we can build upon the imaging findings, mainly looking at the PET-CT or gallium scan. Nowadays, most often we perform the PET-CT and not the gallium scan. So this is about the diagnosis of sarcoidosis. Now, if I have to talk about the management, sarcoidosis generally shows good response to steroids. Okay, so like whatever we have spoken so far, right, like the Lofgren syndrome, Hereford syndrome, they show excellent response to steroids. Many times I do personally believe that those diagnoses are not established because before patients come to us, quacks would have given steroids because they present with typical acute febrile illness. Quacks give steroids and they respond well, right? Similarly, cardiac sarcoidosis can present with heart failure, which shows excellent response to steroids. Heart failure improving on steroids, a known manifestation. Okay, so management wise, right, the treatment of choice or drug of choice is going to be steroids, mainly prednisolone. We start with a dose of around 0.5 to 1 milligrams per kg per day in divided doses. So we go on to give it to the patient for around 8 weeks. Then it is tapered. After that, patients would require maintenance with a low dose of steroids. Low dose, which is like 5 to 10 milligrams per day. This is in most cases continued for around 12 months or 1 year. Most of the patients we will be able to stop. Now, there are two problems. One, either patient may not respond to steroids in the first go, okay, or there may be recurrence. So I can say treatment failure or recurrence. In those cases, what are our options? So if there is treatment failure or recurrence, in those cases, our options will be first line agent will be regular immunosuppressants like azathioprine or your tacrolimus, okay, mycophenolate, mofetil. Those are our first line agent. Second line agent, we think of biological. So rarely ever a patient is not responding to aza, tacro or MMF or any other immunosuppressant you've chosen. In those cases, we think of biologicals. And when I think of biologicals, mostly they will be targeting which one? See, what is involved in the granuloma formation? Interferons and TNF alpha. So mostly we will use anti-TNF alpha agents like adalimumab, golimumab, or any other anti-TNF alpha agents can be considered. That will be the second line agent. So we start with intense steroid therapy of 8 weeks and then we switch to maintenance. But anytime during the intensive therapy or maintenance, if there is failure or there is relapse or recurrence, then we introduce immunosuppressants. With that also, if there is failure or relapse or recurrence, then we go ahead with anti-TNF alpha therapy. So that's the last line of management for a case of sarcoidosis. So with this, I'm signing off, guys. I'll see you in the next video module talking about another important topic. Till then, have a good time.